Type 2 diabetes is more than a struggle with blood sugar. It is a systemic condition. Over time, inadequate insulin use leads to persistent hyperglycemia that damages microvascular and macrovascular systems, which restricts blood flow and threatens long-term organ health. Historically, the medical response followed a standard opening move. For nearly every adult diagnosed with the condition, the first step was a prescription for metformin monotherapy. Success was measured by how effectively a doctor could succeed in driving down one specific data point, the HbA1c number. This metric, which tracks average blood glucose over several months, became the primary focus of clinical management. This uniform approach prioritized reaching a standardized glucose target over identifying and addressing the specific cardiovascular or renal risks unique to each individual. The 2026 update to the NICE NG28 guidelines replaces several historic documents and moves away from the standard rule of starting everyone on metformin alone. The new guidelines prioritize a patient's phenotype. This means treatment is now dictated by a person's specific health profile, including their heart and kidney function, rather than a universal protocol. Because this condition affects multiple organ systems, the treatment plan requires a targeted strategy that addresses the patient's most immediate health complications. Even with new medications, the foundational steps of the pathway remain constant. Every patient begins with structured education, a personalized lifestyle plan, and a framework of 9 annual care processes, ranging from BMI checks to retinal screenings. There is a common misconception that every patient needs a continuous glucose monitor or daily finger prick testing. In reality, these tools are reserved for those using insulin or those at a specific risk for hypoglycemia. The most significant change occurs at step 3. For most adults, the starting medication has shifted from metformin alone to a dual therapy approach, combining modified-release metformin with an SGLT2 inhibitor. This starting point is designed to address the disease through multiple biological mechanisms simultaneously, rather than waiting for a single drug to fail. Clinicians are no longer just reacting to a high blood sugar reading, they are establishing a multi-layered defense from the day of diagnosis. Following that baseline, the pathway shatters into distinct branches dictated by specific comorbidities. In the kidney branch, treatment is guided by eGFR thresholds. Once kidney function drops below 30, guidelines move the patient toward DPP-4 inhibitors to manage glucose without overstressing the renal system. For patients with established cardiovascular disease, the guidelines trigger a different escalation. This pathway specifically introduces GLP-1 receptor agonists, such as subcutaneous semaglutide. If a patient is living with obesity, the pathway introduces tirzepatide, but only after 3 months of initial therapy have passed and targets remain unmet. Conversely, for patients where frailty is the primary concern, the priority is to use the smallest number of effective medicines at the lowest possible doses to avoid complications like low blood pressure. This system requires a physician to select a drug based on which organ is most at risk, moving past the era of uniform glucose lowering. If these targeted oral or subcutaneous therapies are not enough to meet targets, the protocol moves to step 5, the introduction of insulin-based treatments. Starting insulin requires a new level of support, including education on injection rotation, managing dose titration, and legal requirements for driving safety. Finally, step 6 focuses on long-term surveillance. If routine checks reveal retinal damage or severe foot complications, the patient is moved out of primary care and into specialized hospital pathways for intensive management. This safety net ensures that even as the condition progresses, the clinical response escalates in a way that addresses the patient's individual risks. Within the Step 4 escalation rules, there is a specific directive regarding SGLT2 inhibitors that clarifies the new philosophy of these guidelines. Doctors are now advised to continue prescribing SGLT2 inhibitors for their cardiovascular and renal benefits, even if the drug does not help the patient reach their target HbA1c level. This is a direct instruction to prioritize the protection of the heart and kidneys rather than the blood sugar number itself. By tailoring the strategy to a patient's heart and kidneys, modern care moves from balancing a blood sugar metric to actively preserving organ function.